those questions in the GISC mail, and then it could start to promote individual learning with each other. So hopefully that will make sense. I know some people have joined since we let everyone in, so I'll just very briefly introduce myself and then I'll hand over to Toby. Again, so I know some of you who were here earlier have already heard, but I'm Jo Howe. And I've recently stepped into a role as an independent researcher. So I'm working for myself now, but still very much linked and developing the work that I have been doing at Aston University with Professor Ian Maidment, who's Professor of Clinical Pharmacy. I'm a chartered psychologist by background, and for the past 4 years, we've been looking at non-pharmacological strategies to manage antipsychotic related weight gain, which is how I became interested in the physical health of people with serious mental illness. So that's a little bit about me for those that don't know me. If anyone wants to connect, please do so and get in touch. And Toby, I'm going to introduce you now. So Toby and I have known each other for a few years ago because I stumbled across his work. I stumbled across a protocol, I think it was, that you'd published. And then spent a few hours trying to track you down because you didn't have much of a social media presence, so that was hard.
Still don't.
So Toby has recently graduated from his PhD over at Loughborough University and is now working up at Northumbria University on a trial. I can't remember the exact wording of your trial that you're working with Nicola Clibbins on, but it's around crisis management of serious mental illness. Is that correct?
Yep.
Yeah, okay, well remembered that. Well, I was dredging my memory there. But today you're going to talk to us about how physical activity as an intervention can be an effective evidence-formed intervention within inpatient mental health care. And you're going to explore how movement and physical activity programs have been found to reduce violence, foster hope, and also help to break the cycle of revolving door admissions. And that's something that came up again and again in the research that we've been doing, the challenge of how to break that cycle. So you're going to use real world examples, and this hopefully will help us challenge how to rethink the environments that we create within inpatients and how much control patients and staff really have over activity within these settings. So you're going to offer some practical tools for immediate implementation, which is always a bonus in these settings, and as well as asking what's next for research and what systemic shifts are needed to make movement part of everyday care. So I'm guessing, Toby, that's a call out to us to say, please get involved in a discussion with you at the end.
Yes, please.
Yeah. So please, people, put on your brave pants and talk to us afterwards so we can help Toby work out his next steps. So those that had their hands up, hopefully you've got the link from Lauren in the chat, and if you can lower your hand, that would be great so we don't get confused with hands that are raised during the chat. So Toby, do you want to start sharing and we'll get going? Yeah. Hopefully everyone who's turned up. Lauren, how are we recording? Yes, we are. Perfect. Thank you. I always forget, so it's nice to know that someone else has my memory. So I'm going to turn my camera off, Toby, and over to you. Let me know if you need anything as you're going along, and I'll alert you if anything drops out.
Great. Thank you very much, Jo. It's an absolute pleasure to be invited to come and speak today and in the Mental Health and Innovations Network. I've had the pleasure of attending previous lectures and intend to be a part of this network for the foreseeable future. So I realised that spec was written, I think, for Jo maybe a couple of months ago. And since I've developed the slides, we're mostly going to be talking about lots of the topics mentioned in kind of the advertising. So, and what I'm particularly going to be talking about and focusing on is this idea of impact and implementation. So we know that exercise is good for us, but actually now we're getting to the stage where we need to actually start implementing these programs and these strategies. And hopefully today you're going to leave with some ideas of potentially how you or people that you know could start to deliver and implement physical activity in psychiatric settings. So just a quick disclaimer that we're going to be talking about severe mental illness and psychiatric settings. So this may be a topic that people find distressing, so please feel free to leave the chat and leave the room at any stage if you please. So as Jo said, just quickly about me, my PhD was at Loughborough, and it was particularly looking into physical activity in inpatient care, and me and Jo kind of connected over that realist methodology and severe mental illness aspect of things. So that's kind of what I'm working on the Pioneer study up at Northumbria, which is evaluating police involvement in mental health crises within the community. And yeah, that's very much using realist methodology, which again is a methodology that's used a lot to evaluate interventions and programs, and to understand what's working, how it's working, and why it's working. And yeah, I'm just a early career researcher, and I've got a few papers coming out, and I've been involved in various bits and bobs. And today I'm going to be talking about physical activity and exercise. So I guess today we're going to be I'm going to explore the evidence a little bit. I'm not going to go into it too much. And then what I really want to talk about is a lot of the key psychological theories and models and ways of thinking that can help support how implementation can be promoted, and kind of using those evidence-informed models to make our decisions and to design programs. And then I'll just share, I've got 5 kind of practical tools and takeaways. And then, as Joe said, hopefully we'll have some time for discussion. So please note down any questions or ideas that you have, and I'd be really up for discussing them and chatting. So I guess one of my main goals is not just to help to inform you on your own practice, but also maybe this might be an opportunity to reflect on your own physical activity behaviors or friends and family. So a lot of the things I'm going to be talking about are going to be transferable. So I know at times they will be specific to mental health and mental illness, but hopefully there'll be some takeaways which you can even start to implement into your own life. So something that I think is really important is to actually start with really understanding what physical activity is, because I think sometimes it gets confused with other definitions such as exercise. But physical activity is defined as people moving, acting, and performing within culturally specific spaces and contexts, and influenced by a unique array of interests, emotions, ideas, instructions, and relationships. So that really places physical activity in that kind of social context, whereas kind of older definitions were more based around kind of skeletal movement and energy expenditure, rather than this one. This is kind of more, this includes that, but also encompasses that social context and the reasons why people engage in those interests, emotions, ideas, and relationships. So hopefully we can explore this a bit more later in the session. And kind of just examples of physical activities. These could be kind of movement, transportation, leisure time. It could be cleaning the house, it could be dancing, it could be gardening, but it also encompasses participating in sport and in exercise. So I guess exercise is a subset. Well, it's not, I guess. I mean, exercise is a subset of physical activity. And this is more based around kind of structured, planned, and repetitive physical activities, with the objective of improving or maintaining physical fitness. So it's kind of more based around that kind of cardiovascular focus and fitness focused, rather than physical activity would be more kind of based around movement and all the other things that are involved in that. And there are, World Health Organization guidelines on kind of recommended amounts of movement. I'm not going to talk about them too much, but the research supports the idea that even small amounts of physical activity can have important outcomes for us as humans. So I thought maybe it could be a good opportunity at the start of the talk, which would be to encourage you to maybe reflect on some of your own physical activity behaviors, or maybe when you work with patients. So it's just this kind of question of maybe, do you participate in physical activity yourself? And if so, what physical activity? And also maybe just start to reflect on why you do that physical activity. And maybe, like I said, you could reflect on this at the end of the session. So physical activity for people with mental illness and severe mental illness has been recognized. These are examples of leading papers in the area. They're a bit outdated now, and we're going to talk about more up-to-date evidence, but physical activity has been recognized as an important component in the physical health and in the lifestyle for people with severe mental illness. And it's been found to have multiple benefits. Like I said, I'm not going to go into this too much but it's important to quickly discuss that it's been found to help with the symptoms of severe mental illness, so kind of depression, anxiety, and has also been found to help with psychosis. But that's to a lesser extent. It's helped, can help improve sleep quality and fitness. It's also been found that people who engage in more physical activity have reduced treatment duration. It has normalizing effects. People are more likely to engage with services and adhere to medications. And also, actually, they've found that in a lifestyle intervention where physical activity was a part of it, they were able to, if people would engage in more physical activity, they were able to reduce the amount of antipsychotic prescription, which we know is super important in this population due to the adverse side effects on the physical health of people on these medications. And then also for people with severe mental illness, the general benefits reflect that of the population, which I feel a lot of us are probably already aware of in terms of body composition, reducing inflammatory markers, reducing cardiometabolic risk, improving mood, for anger management and memory. So I guess, are there particular physical activities that are related with good mental health? And yet again, this has just been published in the British Journal of Sports Medicine very recently. This is a 2025 paper, actually just came up on my LinkedIn. And what they found was that leisure time physical activity, transport related physical activity, occupational, household, and to a lesser extent, physical education was positively associated with better mental health. So how is it working? So I'm not going to go into this too much again, but there's those kind of physiological outcomes, which physiological mechanisms, which I'm sure a lot of us are aware of in terms of serotonin and dopamine. That's in the monoamine hypothesis, endorphins. But today we're going to be more talking about these psychological mechanisms a bit more. So the social interaction hypothesis, enhancing self-efficacy, so based around kind of mastery and competence, and also there's the distraction hypothesis. So just a quick overview, this is a mental health setting on a mental health ward, which is where my research has been conducted. However, like I said, the tips today will be applicable and transferable across various mental health settings. So this is just this is a common room where patients might relax and watch television. And then this is kind of the outdoor space, which patients might exercise in, but maybe you commonly find people vaping, even staff vaping with patients. So these are all the things that are kind of some of the barriers that you find in these environments. And this is yet again a 2025 paper, which has yet again been published in The Lancet. So that's following on from the last one. And this is just about the importance of the implementation of lifestyle interventions. Like Joe was saying, these holistic, non-pharmacological interventions in mental health care. This is like a leading paper within the area. And it talks about all the different aspects of lifestyle. And these are like risk factors that are particularly prevalent in this population that are driving really serious physical health disparities. So, we've got smoking, unhealthy, poor quality diets. We've got physical inactivity, sedentary behavior, poor sleep hygiene and sleep quality. And these are all driving these physical health disparities, which we find in this population, which is people with severe mental illness are 1.5 to 2 times more likely to be at risk of cardiometabolic disease. And 70% of deaths in people with SMI are from these physical health conditions. So that's really serious. And, there's a real ethical imperative to start to address these physical health disparities, because these conditions drive a 13 to 15-year reduction in life expectancy compared to the population. So this is kind of quite well known within our area. So this is kind of, we really need to do something about this problem. And kind of more concerningly is that actually when people come into secure locked ward environments, mental health settings where there's a primary focus around mental health, which is mental illness, which is obviously very important, where sometimes the physical health of patients often deteriorates and is exacerbated in these settings. And that's because it's a predisposition. It predisposes patients to high amounts of sedentary behavior, high medication prescription, which creates kind of obesogenic environments on wards, where they also have unhealthy ward cultures, where there's poor quality food, kind of what I was saying, you know, that unhealthy ward cultures where also you might see staff members engaging in these poor physical health behaviors with the patients, such as, you know, smoking, rather than encouraging kind of healthier behaviors, which has been found in some settings, which kind of drives up to 80% of patients have been classed as obese or overweight in medium secure settings. However, like optimistically, when people come into these settings, it's also a good opportunity to start to engage people in healthier lifestyle and to intervene in these poor physical health problems that people are maybe experiencing in the community, rather than when they come into a hospital, they're in a more kind of environment where they have more access to support. So this is kind of one of the concluding things in that Lancet paper, which is we know now that there are established benefits of lifestyle interventions, of engaging in physical activity. So now we need to shift our focus from efficacy towards implementation and to addressing how best to implement and deliver lifestyle interventions within clinical practice. So that's kind of where a lot of my research has come in and what I'm going to be talking about today. So what I kind of wanted to talk about and support what I was going to say, where I think it's important to understand some key psychological theories, models and evidence within the research area in regards to how we can get patients to be more physically active and maybe to understand why patients aren't physically active. And what I wanted to start with was talking about rational choice theory, which is actually a very old theory that was developed in the 1700s by actually an economist. And it's kind of about this idea that human behavior is kind of that assumes that individuals make choices to maximize their interests by weighing the costs and benefits of their actions. So it's kind of this idea that we make a rational calculation. Okay, yeah, I know it's going to be good for me, so then I'm going to choose to engage in that behavior, and then I'm going to get the outcomes aligned with our interests. So we're always kind of going to make the right decision for ourselves all the time, always to maximize our self-interest. But maybe this is a reflection. This was another kind of idea that I thought would be interesting for you to reflect on, was like, how rational do you believe we truly are in our lifestyle and health-related choices? Because I guess, you know, we know physical activity is good for us, of course, so surely rationally we would make a choice, and that would be to engage in more physical activity, which would then result in the outcomes that we want from engaging in that physical activity. But I'm sure, as you probably might be thinking, that actually isn't probably quite as realistic as actually the reality of this of these outcomes. So I wanted to really start with rational choice theories, as I think that this kind of way of thinking also is still really prevalent within healthcare and within the population over around our health behaviors. So what are these critiques of rational choice theory? So like I was saying, there's unrealistic assumptions. So it assumes that people are perfectly rational and always act to maximize utility, which doesn't reflect real human behavior. And it also overlooks how culture, norms, the environment and relationship influence our decisions. So there's always a lot of other things that are influencing the choices that we make around our health. So it often fails to explain behavior in complex or uncertain situations. And people also frequently act irrationally due to biases and emotions. So we don't always act within the most rational, in the most rational way. So I'm going to be talking about that a bit more. And I think that links on nicely to people with severe mental ill health. And that's because it's been found within the research that people with SMI often display even higher levels of self-management difficulties compared to the population. And that's, you know, due to high medication doses, illness-related symptoms, and also systemic barriers. So I guess then if we're more looking at physical activity, traditional physical activity interventions such as goal setting, educational content, motivational interviewing is kind of underpinned by this idea that if we set goals with people, or if we tell people that exercise is good for them, then people are going to self-regulate and they're going to be motivated to do it. However, these kind of more traditional cognitive rational approaches usually overestimate rational decision-making capacity in humans. So I hope this makes sense. And this is also been found as something, and is reflected in something called the intention behavior gap that's been found in this population, whereas as we know, kind of there's a lot of low motivation in patients, and that's frequently reported as one of the main barriers to engaging patients, is that people just don't want to do it in that moment in time. But 30 to 50% of people with SMI still express a desire to be more active, but then that doesn't actually mean that the people are doing it. And that's called the intention behavior gap. We intend and we want to do it, but actually we don't do those behaviors. And this is, reflected in the wanting to do something is not the same as doing it. And I think that's really what we found, particularly in some of my research throughout my PhD. And this is kind of going to underpin some of the tips and takeaways that I'm going to be discussing. So I guess, how do we overcome this? And first of all, it's kind of through environmental intervention. And this is, we need to stop moving away from tailoring our programs just to the individual, and rather than we need to start actually focusing on creating motivational and effective environments around the individuals. So how do we start to overcome those individuals' kind of poor motivation, lack of motivation to engage? And that's by making the things around them and designing environments to make people more likely to engage in physical activity. So this is another finding that we've spoken about a lot, and this is called the socio-ecological model, or kind of taking a multi-level approach. So to actually deliver successful physical activity programs, we need to target lots of different areas of the environment. We need to look at the leadership and organizational environment. Is there enough funding? Then we could even look even higher into like the policy. And then, the physical environment, is it designed in a way, if you're on a ward and people are on certain sections and they can't leave the ward, are there opportunities on that ward? Can you encourage people to walk upstairs rather than go in the lifts? And then really looking at the social and relational environment, which we found was kind of really interesting to engage people in physical activity environment, and also the individual. So like we were saying, giving people choices and looking at what that individual wants to do, but we need to look and intervene at all levels of the system. So to have an engaging physical activity program, it requires multi-strategies, a multidisciplinary approach, an adaptation to that kind of social, physical, and leadership context that the program is being delivered in. And this involves, looking at culture, so changes in culture, the service structure, and the delivery of physical activity. So some of you might be aware of this theory already, and it's Decky and Ryan's basic psychological needs theory. And this is kind of the concept that we have 3 core psychological needs, and when these are all satisfied, we're going to be more intrinsically motivated and driven to engage in behaviors. And it's been found to be one of the strongest predictors also of exercise adherence. So the basic psychological needs theory emphasizes that creating social environments that directly influence these 3 innate and essential needs are kind of the ingredients that you need to create an effective environment, a motivating environment for patients. So how can you do this? So autonomy is the experience. We all kind of have a drive to have a willingness and volition and choice over what we're doing, and also within psychiatry, it's particularly complex. People have had a lot of their choices taken away from them. And I know there's a big emphasis in the NHS on least restrictive practice. So how can we actually start to give people a sense of autonomy, because it's commonly undermined? And one of those ways is through physical activity. And what we found was that it's actually very important to include service users in the decision making, but also to avoid feelings of pressure and making physical activity compulsory. So not forcing people into doing it, not forcing them to do things they don't want to do, but letting them choose. And sometimes they might want to make the choice to let you choose for them. You know, you're the exercise guy, you're the physical activity guy, you just tell me what I want to do. But still, that's still autonomy promoting. So we have an innate feeling of being connected, having a sense of warmth, bonding, and feeling cared for within our environment. And physical activity, yet again, to promote physical activity, we really need to emphasize these experiences of feeling connected. So sometimes what we found was important to build these relationships even prior to the delivery of physical activity, building those therapeutic and supportive alliances, and also just by promoting a sense of community and acceptance on the ward. And this is particularly important when we talk about culture and making people feel cared for. And that was particularly important within exercise. And so really focusing on making people feel connected and having a sense of kind of relational bonding with people, whether that's with other patients or members of staff, is really important. And then lastly, competence. So making sure that people have a sense of mastery. So what they're doing, they feel good, they feel effective, they feel competent in what they're doing. So this is really important to make sure that physical activity experiences are small, achievable, and rewarding for patients. So not, you know, I'm going to give an example in a second, but it's really important to avoid feelings of failure, insecurity, and doubt. So this is an example that we got from a member of staff that I was working with, and he said that we've got some guys from the army to come in and take the session for the patients. We were told by leadership to get the patients sweating and working to lose weight, but we found the week after none of these patients wanted to return. So I guess this is how we fit into this kind of autonomy and this competence, which was, you know, they were doing things which were really unachievable, were really unenjoyable. There were feelings of failure. There were people potentially shouting at them, telling them what to do, how to do it. So this is kind of really thwarting these key basic psychological needs that we need to feel kind of motivated and have good well-being and feeling satisfied. And then this also links nicely on what I'm going to talk to you about next, which I'm a big fan of, which is this concept of affect. And affective responses refer to the pleasure and displeasure that an individual experiences. And this is kind of based in, it sits nicely within this kind of hedonic theory that affective responses and memories of these responses have good motivational value. So really, we seek to repeat experiences that are pleasant and to avoid those that are unpleasant. So we're actually just very motivated to do things that make us feel good, which I guess, you know, when we talk about the army and doing, okay, you might get a sense of satisfaction afterwards because you've completed it, but actually how pleasant do you feel, and how these kind of unpleasant feelings become kind of encoded into our memory, and the memories of these responses then really affect our motivation the next time that we go to engage in these behaviors. And I'm not going to talk about this because we're running out of time. And this is a really good paper that I recommend if people are interested in this kind of idea of positive affect. So making this paper kind of discusses the importance of, instead of focusing on the health benefits of physical activity, it's really important to actually more focus around the positive and pleasurable experiences that you can gain from engaging in physical activity, rather than long-term kind of health benefits. And I'll talk about two kind of concepts that fit nicely within this kind of idea of affect. The first one is called delay discounting. And I think this is something that a lot of us, well, I think all of these are things that we can relate to. And this is a self-regulating process where the immediate rewards and impulsive preferences, so the things that are immediate and are there, commonly hold more subjective value and gratification to us as humans than larger rewards and outcomes remote in time. So I guess this is an example of You're sitting at home, you're relaxing, you're with your family, you've got nice sweet treats, you're experiencing all of these positive, these pleasurable, short-term kind of immediate rewards. And then someone is going to go, come on, let's go for a really high intensity run. This is going to be really good for our fitness, and for our cardiovascular health. Commonly most people are going to say, actually, do you know what? I think I'm just going to stay in my nice kind of warm, comfortable house with my family. So that's that kind of concept of delayed discounting, where we really focus, we're a lot more short-term focused, we're a lot more impulsive, and we're a lot more focused around immediate rewards rather than long-term rewards, kind of in a more long-term capacity. And actually, this has been found to actually be even more prevalent in individuals with severe mental illness. So they've been found to show greater impulsive delayed discounting. And this is an example that came from a paper by Cody et al. In 2023, and they were working with patients in an inpatient setting that had depression. And what they found was actually longer term outcomes to people with major depression in this setting longer term outcomes were often perceived out of behavior control and too far in the future. Rather, it was actually just really important to focus on promoting the benefits of physical activity and what they wanted at that moment, which might have been to just go for a walk. It might have been to have some like green space, and to kind of derive those more kind of positive outcomes, rather than really focusing on, if you go for this walk, it's going to be really good for you in 20 years, for example. And I think, this is also very applicable to lots of other areas, maybe to like medication adherence, etc. Whereas, taking certain medications to prevent something 20 or 30 years down the line, it might kind of it might be perceived as out of kind of behavioral control and too far in the future. We're going to be prioritizing what's important in that moment. So optimistically, I guess, how do we overcome this? And it's actually been found that more kind of in physical activity, it's really important to focus on enjoyment, relaxation, and social interaction, because these can actually start to act as those immediate rewards. And these become more motivating, those immediate rewards, than delayed goals like fitness, health, or weight loss. And the way that I've actually seen this happen in practice myself is, okay, you're relaxing. Why don't we do some dancing? Come on, it'll be fun. Why don't you choose some of your own music? We only have to dance. I've actually seen physiotherapists go up to patients and say that they can choose their favorite song that they can listen to, and then we're just going to do some sit-ups for 3 minutes. And once that song is over, then we'll sit back down. You can carry on. It's not going to be really intense. And then, and also, the other example is gardening. So this can be also perceived, actually, it's kind of low energy, but it's pleasurable. We can go and do it with our friends. It's relaxing. And these immediate rewards kind of hold a lot more value to us rather than these long-term rewards. So hopefully that makes sense. And then the next one I want to talk about is effort discounting, which I'm sure we're all kind of aware of, and it's kind of an evolutionary mechanism to conserve our resources and our energy. And this refers to the concept that mental and physical effort is costly, and that we kind of naturally we generally favor kind of low physical effort. And this is kind of usually found, I think, during the initiation of behaviors. So usually once we're kind of getting going and we feel good, then actually it's not too bad. But actually, oh no, I'm good, I've had a long day, that, physical effort, going out for that run, that seems kind of really effortful. I think I'm just going to relax, and maybe I'll do it tomorrow. That's kind of the classic. So we kind of, if something is perceived as quite effortful, then we usually, a lot of the time, it takes quite a lot of mental resources to overcome this and to engage in these behaviors. And in particular, for people with severe mental illness in psychiatric mental health settings, people are already engaging in lots of effortful activities and therapies. I've got music therapy on here. I've just got a kind of more general therapy session, whether that's CBT or they're having psychology, they've got ward rounds. So a lot of these kind of high effortful experiences are something which patients go through every day. So then the thought of then going and doing a really, really effortful exercise or physical activity session of really high intensity is not something that a lot of the time people are going to want to do. And this is kind of also transferable into the kind of more general population around maybe people are, they have children, they have a job. So the idea of then getting home after it gets to 7 o'clock, the kids have gone to bed. What do they want to do? They just want to relax. They don't want to go and do these things that are high effort. So I guess we've got to find ways to overcome this kind of effort discounting that is found in these settings. And I guess one way what's been found to reduce perceived effort is to encourage people to kind of self-pace. And when they do engage, to do them at comfortable intensities that improve effective experiences. And that kind of initiation is usually due to pleasurable and achievable past experiences. So I guess with a patient, if we're like, well, come on, let's go and do this walk. Last time, it was actually really fun. We only walked for 10 minutes. We had that really nice chat. It was relaxing, and then you came home and you could sleep. These kind of things really help to overcome that effort minimalization. So these experiences lower future expectations of perceived efforts. And this is a model called the effects regulated physical activity model, which is kind of how exercise behaviors are usually an outcome of these effective experiences and these effective memories, these feelings of pleasure or displeasure, and how that actually has a really substantial impact on whether we go and exercise. And one of the main things, for example, was in patients with severe mental illness, a lot of them have had previous negative experiences of physical activity. So whether that was at school or other times where they tried to engage and they failed, and actually it was a really awful experience. So then the idea of exercising or engaging in physical activity is like, no, I don't want to do it. So actually it's really important to help us to start changing those feelings, and by doing that, being self-paced and doing kind of low intensity, and then just having enjoyable experiences. And it sounds really obvious, but that's what the kind of research suggests. So the outcomes of physical activity, and I was talking about this with Joe, and I know I've kind of already touched on it at the beginning, which is some of the main outcomes of kind of more outcomes which are more established within literature, whereas I think it's time to start to reframe within these settings, actually, what are the real kind of important outcomes of physical activity for our patients? And I think, first of all, this is kind of rooted in definitely the changing space around GLP-1s, GLP-2s, semaglutide, which is used to start to address a lot of those physical health disparities that I spoke about at the beginning. So I guess it's, how does physical activity fit within lifestyle psychiatry, and what actually role can it play in lifestyle psychiatry if we're going to be using these drugs to start to address some of the more serious physical health issues that are faced by this population. And this is this was published by the World Health Organization, and these are the 4 things that they say helps to make up good mental health, and that's around kind of connection, being able to cope, being able to thrive, and being able to function. And I think we need to start thinking about how physical activity can play a really key role in a lot of these functions. So I guess when we talk about developing positive relationships, especially in inpatient settings where relationships are also sometimes very complex and fractured, and it gives people a sense of belonging, on a ward, coming together, exercising together, helping people to cope, deal with stress, adapt to change, come up with new ideas, help people to thrive, to feel good, to do things, to be physically active, and also to learn new skills, that kind of mastery, and to help to develop kind of to promote social interaction and the cognitive benefits of engaging in physical activity. So a lot less focus around the physical health, but the real psychosocial outcomes of physical activity. I'm just aware that I'm running out of time. And this is kind of what we found in our research, was how actually physical activity could be used to help build hope and self-esteem for patients with severe mental illness. And this model is the illness identity model, which was developed by Janos, and it's a really interesting model. And it's about how a lot of people with severe mental illness have a lot of self-stigma, and they're aware of this stigma and how this affects their hope and self-esteem of getting better, how they feel about themselves. And it was how exercise can actually be a really key mechanism in helping to build that hope, give and help people to work on themselves and build self-esteem and engage in something new. So when people are discharged, and I know we spoke about revolving doors, etc. And what we actually found was when people are in an inpatient hospital, if we help people to build this hope and self-esteem, then people are a lot more likely to take their medication when they go into the community. They may be less likely to relapse, or maybe if they've had drug-induced psychosis, for example, they may be less likely to engage in those behaviors because maybe they've joined a football team or now they go to the gym. It kind of helps them to reinstate a sense of purpose, control, and self-esteem in their life. And these are preliminary findings that we found, but these are definitely something that we're going to be discussing in future publications. And also, really interestingly, what's been found is that physical activity can be used to reduce violent incidents, rapid tranquilizations, and restrictive interventions. And this is just a case study which we've also conducted some research on a ward in London, on a PQ ward, so a psychiatric intensive care unit. And alongside weekly cooking sessions, the physical activity program was able to reduce violent incidents by 35 to 51%. And actually, I've been invited, or I'm working with new colleagues who have actually found very, very similar findings. So this is something that I think physical activity can play a really, really important role in reducing restraint and building increasing collaboration, therapeutic environments, and improving those kind of clinician and patient alliances on this ward. And this result, and also not just for patients, but also for staff, this improved confidence, retention, well-being, and job satisfaction. And this is obviously really important because high staff turnover on these wards is a real issue. So this is kind of an example of how physical activity can play a really important role in the kind of social outcomes for wards. So as I said, I'm going to have 5 practical tools and takeaways, and then I'll be finished. So just to kind of wrap up, I guess the first one is to avoid a sole reliance on the individual to make behavior change. Our patients don't want to be active, so there's nothing we can do. So it's that self-management is often impaired for people with SMI. And we kind of over rely on this kind of concept of rational decision making for people and ourselves, which is not always realistic. So we need to start to adopt multi-level approaches. So we need to start looking at our culture, our service structure and delivery models, and creating environments that support daily physical activity for patients. There's a lot of things that I haven't had the time to talk about today, but they'll be in a paper that we're going to be publishing very soon. A focus on the psychological needs, so the basic psychological needs, so the concept of autonomy, competence, and relatedness, and satisfying these, and then emphasizing the immediate rewards, prioritizing the enjoyment, the positive affect, relaxation, the social interaction, and physical activity being fun, rather than it being kind of really overexertive, effortful. And making sure that these experiences are kind of achievable and adaptable to these individuals and pleasurable. And then also, just lastly, I hope you can start to take away that there are also a lot more kind of broader psychosocial benefits of physical activity that extend way beyond weight loss, which have been found to include, like I said, violence in reduction, improvements in well-being, and just in general more engagement, which, can be seen in the short, medium, and long term, both for patients and the ward. Great. So just a shameless plug, like I said, this is a paper that I've been doing with Joe, and it's been going on for 4.5 years. So it's really great that it's going to be published. This is we're just completing the preprint now. And then also I've got a consensus piece that's going to be coming out soon with 33 multi-level strategies for implementation in mental health settings. So if you're interested, make sure you look out for that. And that's also under review at the minute. So thank you very much for listening. It would be great to connect with people. So please feel free to contact me. This is my email. And yeah, I'll just hand back to Joe if people have any questions. And here are all the references that I've spoken about today, if there's anything that has caught anyone's eye. So thank you very much.
Oh, thanks, Toby. That was great. I know I got involved in your project towards the end, so it's actually quite nice to see some of the previous work that led up to the build-up. And I don't know about anyone else, but it has made me rethink some of my motivations. And I guess it does chime also with the conversation that we had before we started, which is around like, what are the outcomes that we are looking to generate from physical activity? Because we know across the literature that the lifestyle interventions don't really yield any long-term benefits for reductions in the weight to help with the physical health. So I think that's just an interesting way of framing it. So I don't know if anyone has any questions for Toby. Pop them briefly in there. You can put your hands up, but you can also pop them in the chat if you don't want to ask it, and I can ask on your behalf. If anyone's got any, I think you want to open up for discussion now around literally, around the ward environment. And I know, so previously before I worked in mental health, I worked in stroke. And there's been a lot of work done in stroke services around the enriching environment and the need for that to be able to promote rehabilitation following stroke. And this to me feels like a similar kind of shift as what you're suggesting, is we need to think very consciously about the environments and ensure that they are built for purpose, built to be able to promote these kind of activities. So yeah, and we've got someone with a question. So yeah, is it Piri or Brooke? I'm not sure which way around your first name is.
Perry.
Perry. Sorry, got that completely wrong.
Hi, Toby. How are you? Hope you're doing well. Good talk. Enjoyed it very much. What I was thinking about when you were giving a talk, maybe this is less of a question than a statement, is also because you're talking about the value of exercise in helping with severe mental health. But is there the idea that it can also be preventative? So getting people involved in physical activity earlier to help the onset of severe mental illness.
So it's kind of around the kind of preventative.
Yeah.
I don't really know, but yeah, I'm sure there's probably some research. Oh, is there not? Okay.
There's not. There's not. So this falls very squarely into our camp, Perry, and it's something that we have looked at extensively in Resolve. So we looked at non-pharmacological strategies to manage antipsychotic related weight gain, with the emphasis being on that as the proxy for the development of the other physical health conditions. And I think out of all of the papers which were identified, which I can't remember exactly how many, over 100, I think 1 or 2 had looked at this preventatively. And this is my big bugbear at the moment. This is my big, what I would like to do is start to change this narrative, because currently we know once the weight has been gained, that it's very difficult for the weight to be lost unless you are going to add in something like a GLP-1. But actually, we don't really have any evidence for anything preventatively at the moment. So I'm working with a number of trusts across the UK for them to develop QI projects to be able to look at this from a preventative strategy. I'm also developing a resource which includes a physical activity component to be able to be given to people at the point of prescribing. So if this is a conversation that you're interested in having, get in touch, and we can maybe open it up a little bit wider. But I'm looking to try, even if it is small scale QI projects, I'm looking to try and gain an understanding of what can we do preventatively, because these small scale projects, we can collate them together to come up with something bigger. But the answer is we do not know at the moment if we can do anything to mitigate like weight gain, if we can mitigate the development of these future physical health conditions if we get people early enough. So the research evidence just doesn't exist. And there are no big trials, apart from the new metformin trial that's out at the moment, Metric. There are no big trials that are designed to address this. So again, I think it's something, we do need something in this space, and QI projects and service development yield useful data in the absence of anything substantive and formative through stronger research trials. I'm wobbling now, so I'll just stop because I could probably talk all day about that one.
Thank you.
Does anyone else have any more questions for Toby? So I think Claire's put in the chat, the methods section is detailed in the paper. It's not loading on the UOB website. It's probably because it's not fully published yet. Is that right? Just a preprint.
Yes. Yeah, just a preprint for now. So yeah, it's going to be, I'm just currently trying to sort out with the publisher the final manuscripts.
Yes, I think you had the same challenge as we did with our last piece of research, which everything went in looking beautifully, and what came out the other end from editing was a big dog's dinner.
Yeah, so
and it takes days and days and days and days and days to fix.
I've had to spend a lot of time, and I think at the minute it's around the formatting of a table, which is taking a bit of time.
So watch this space. So Toby, when this is published, why don't you share it through the Mental Health Network, and it would be of interest to people who have attended this talk today. There's some really interesting stuff in it.
Absolutely, yeah.
Perfect. So is it Lassie or Lass or any? Go on. I'm not doing very well with names today.
Yeah, hello, Toby. Here. I'm sorry, I've got a terrible cold. Had this for about 6 weeks, but I'm just starting my PhD in Finland on a systems level approach on this topic, and as our first study, we're looking at healthcare professionals' attitudes towards physical activity with the MHII model, COM-B model.
Yeah.
Opportunities, motivations, capabilities. Have you done research looking at healthcare professionals' attitudes, and what sort of measures have you used on that research?
I actually haven't. I've spoken to HCAs as part of my realist work, so I've had kind of qualitative interviews, but haven't actually used any kind of quantitative measures. I'm aware that my supervisor from Loughborough, Florence Kinefik, she's published a paper which is all about HCA attitudes to delivering physical activity, which I think is a very interesting read, but I know it was done in 2018, so I'm sure that the attitudes have changed recently. And also, I think, Joe, this was one of the critiques which kind of came up in my Viva, and also came up in one of the papers, which was a lot of the research that is published is usually, in terms of the facilitators and barriers of physical activity promotion, is actually a lot of the time done from the perception of staff. And a lot of the time this involves a lot of HCA. So I think there was another 2025 barriers and facilitators published recently. I can't remember who it was, but I know a lot of HCAs were included in that. But from my knowledge, a lot of that is usually focused around qualitative work rather than more kind of measures and quantitative. I hope that answers your question.
Yeah, thank you.
An important thing to consider, though, because it's all part and parcel of the wider environment. So, and I know we did have like staff attitudes come up, and I know that in your work that when staff get involved, they're more the physical activity is more likely to be taken up as well. So if staff are physically involved in the actual activity that's being, well, I don't say implemented, run, then
delivered.
Delivered. Yeah, it's probably a better way of saying it. Then the staff are more, then the patient's more likely to get involved as well, because it's seen as a big thing. And you might be interested in next month's talk. Lauren, can you put that link for that in the chat? So Mike Holt from a trust that I cannot remember because my brain is full of other information at the moment is going to be talking next month about doing park runs in forensic settings. So you might find that tangentially also might be relevant to the wider literature around your PhD as well. And it might also be of interest to other people trying to work out how we can organise these activities and get people involved. And that's very much been done from a QI perspective. So Tobias was part of his PhD. This is very much of a standalone service trying to do something to promote activity. And I know in our research as well, we had lots of people saying that when the staff get involved. So I think in one trust for a little while, there was a junior trainee psychiatrist who was, I think, training for a marathon. So regularly went out on runs at lunchtime and the patients went out with them. So I think that, but when they left, that stopped. So, I think it does show you the importance and the involvement that staff can play in this space.
Absolutely, and the role modeling, and also there's a really interesting study which may be worth looking at, which is KBMI, keeping the body
in mind from Australia.
In Australia, and there's a paper which actually they did an intervention targeting staff health behaviors, and then actually they found by supporting staff and making those staff healthier and encouraging them to be have better physical activity behaviors, then that translated into them being more active and delivering physical activity to patients. So that's another kind of interesting study that you may want to consider.
So in this space, the only real intervention that actually seems to show any promise at the moment is the Keeping the Body in Mind study from Australia. But they've developed a whole service around this. So they've reconfigured, and it's holistic. It doesn't just cover physical health. It doesn't just cover activity. It covers psychological therapies. It covers smoking. And so it's a very different service model to the ones that we are currently using in the UK. And I don't know how our service models compare like with yours in Finland either. I'm very interested in how services are organised. So that would be just an interesting thing for me to see if we have a lot of overlap in how our services are configured, or if you have a different structure. Thanks, Lauren, for putting that in. So if anyone wants to sign up for that, we'll also be promoting it through the Mental Health Network, so you can do that as well. So we've got seconds left. Has anyone got any burning questions for Toby? I'll hang on for a few minutes as well. If anyone's got any suggestions for future talks, then I can certainly stay here. And if anyone feels like they want to tell us about something that you've done in your service that's yielded benefits, because everybody's always looking for help. Everyone's always looking for solutions. Everyone's always looking for some nudging forward. How can we make the environment better for patients? So if anyone's got any suggestions, please hang on at 1 o'clock, and I'll stay on for a few minutes as well. But once again, if no one's got anything, there's no hands going up, so I think you're off the hook. So enjoy your lunch, everybody. I hope it's been an interesting talk for you. It will be recorded. Give us about a week to get it uploaded, because sometimes we have a few challenges. The video takes a while before I can authorize it, and I have to then give Lauren permission to access it, and then we go through all sorts of things before we get it uploaded onto the website. But just give us about a week and it'll be on YouTube. And if you subscribe to the YouTube, you'll automatically get notified when any video is uploaded. So if you miss a session, you don't need to worry, because I understand life gets in the way, and these sessions are just there and going to be publicly available. So thank you very much. Enjoy the rest of your day, everybody.